Janet Marchibroda.
And let me once again officially welcome everybody to today's event, Executive Sponsorship of eHealth, Leadership for the Next Wave of Reform. This event is sponsored by the Leadership for a Networked World program and the Government Innovators Network. And without any further ado, let me turn today's event over to the moderator, Jerry Mechling. Jerry Mechling is Director of the Leadership for a Networked World program.
Thanks, Jim, and thanks everybody for showing up. All of those of you who showed up on the East Coast know that it is a wet and cold day. It's a series of them. It's hard to call this spring vacation, but it's what we're trying to make of it. But I think with this kind of technology, we can get into the meat of our day and our topic without worrying about the weather on the outside. I do note somewhat bemusedly that it is approximately 6 minutes after 3 o'clock here, which means we have 1 more minute before Harvard would officially begin the 3 p.m. Afternoon session, since we must allow time for people to work their way down from the yard to the Kennedy School. So in that intervening 40 seconds, let me lay out the general structure that we plan to go through today. I'm very excited about our topic, and what we want to do is both pursue the topic of eHealth and what is happening with it and the important issues that are coming up directly as an issue of health management, health reform. But as we look at those issues, I want to step back and look at the general leadership issues that are being raised in this arena and see the degree to which they operate in other arenas. Let me go over that for a minute or two, then lay out the agenda for the day and introduce our other panelists. The primary question I would like us to address is, what are the lessons that we're learning? And then what are the important next steps we should be taking, and particularly leadership in these issues should be taking on the area of eHealth? So turning to that, I would like us to address it directly in the arena of eHealth, but also more generally. Let me introduce it somewhat more generally, where we have a problem and some interesting discussion about the solutions to the problem. And in this case, in almost any case where the government is working on something, the central problem is that we would like to use public resources to create value for the public that is productive. We would like it to be what the economists would call efficient. We would like it to be fair and equitable in terms of its impact on people in all situations of life and in all locations. And we would like it to be transparent and legitimate in the sense that we know we're not going to get complete agreement on anything we would like to do. And what's very important is that people understand that the decisions that they may disagree with personally have been made in a good faith effort to reach public value and maximize public value for things. In the area of healthcare, I think we have a very interesting problem, because while we have made enormous progress over the 20th century on health delivery, length of life, diseases that can be controlled, lots of progress in the healthcare arena, there's also lots of evidence that says we are not getting the effectiveness or the efficiency that we would like out of the healthcare system. It is a huge fraction of the gross domestic product, which in itself is not bad, except as we look around the world, we see other societies seeming to create equally or even better health results, longer life, better children mortality rates, better health in a number of different dimensions for a substantially lower fraction of their total economic effort and of their individual sort of cost per unit with the various units handled. So there are clearly issues here that are raised about, could we be doing substantially better if we organized and did things differently? Similarly, as you get to the equitable issue, Are we distributing the results from our healthcare systems appropriately across society? There's a lot of concern about uninsured people who are not part of the healthcare system, who are getting poor results from what we're doing, particularly children, particularly in rural settings. So we have issues of equity in the distribution of results, and we also have issues of transparency and our ability to see really what's going on so that we can trust it. I personally can remember doing work in 1966 on the early cost-benefit analysis of what the federal government was doing in a variety of programs, and there was a lot of early optimism behind an approach to measure the outcomes from nursing facilities, nursing care facilities, on a fairly simple Michelin 4-star guide system. And the reality was that once those guides were published, the political reaction was so strong that they had to be recalled. They were considered to be too subjective and not defensible against the enormous onslaught that they got. So in many ways you can say that the problem we're trying to address in healthcare, but also in a lot of other things the government is doing, is that we're not as productive as we would like to be, we're not distributing the results as equitably as we could, and we're not as transparent as we need to be to maintain trust and to control what we're doing very effectively. So if that's the problem, what's the solution? I think there are really two elements of solution that are very interesting to us here, and certainly very interesting to the program that calls itself Leadership for a Networked World. One is that we can organize much of the work of the world fairly differently when we use the capacities of information technology and networking. We can do IT-enabled reforms to have remote service, self-service, outsourced service, different ways to organize things. And much more recently, those reforms are going beyond the individual and beyond the individual program to involve change that reaches multiple independent institutions at the same time, an entire community of action, in this case, the healthcare community. We are not talking about reforms that are isolated within any single component of the system, but we're talking about things like the electronic healthcare record that would be seen by patients, used in medical practitioner operations, passed over to laboratories, parts of that information necessary for the insurance and payment process, etc. We're talking about cross-boundary reforms. But in many ways, we see other policy communities, homeland security, national defense, integrated transportation problems, environmental protection, a variety of other public problems that somewhat, like the healthcare problem, see a potential for significant improvement, but only if the entire community understands and is able to act in new ways. And the critical thing for getting that action is leadership. And for cross-boundary leadership, the critical element is not just what you can do using the traditional bureaucratic powers of budgets and staff assignments and hiring and the traditional internal tools, but we're inevitably talking about political leadership and negotiation that must reach out to individuals and to institutions and get them to agree in a situation which is inevitably anxiety-producing. There may well be people who are in a worse situation than they are today when we're done with certain of these kind of reforms. So we want to look at the e-health operation and the challenges that leaders are facing to see if we can understand what's working and not, what the lessons are, and what the next steps would be, but in particular to feed through the problem and the solution in the e-health context, and then step back to say, have we learned anything that may also apply more generally to public problem solving around the globe in an era when information technology can do a lot. So that's the general problem that we're facing, and we have three very interesting, and I'm delighted to have them with us this afternoon, panelists to talk to different elements of the e-health operation. What we will do is have each panelist talk for about 10 minutes, and then we'll interact on that person's perspective for a while. We will be done with the panelist part and open to Q&A in about 40 minutes or so, although please submit any questions you have as we go along. Our panelists are Bill Braithwaite, who is not only a doctor, he is working with a health information policy consulting group, and Bill will go first, has been a very important person in terms of HIPAA, in terms of healthcare at the federal level for a long period of time, and I'm delighted to work with him again. Bill was able to be working with us here at Harvard about a month ago on a broadly based set of issues that we're looking at the role of standards as we try to do these kind of reforms. Second person that I would like to talk is Janet Marchibroda, who's the Chief Executive Officer of the eHealth Initiative and Foundation. Again, viewing what's going on now, not from just a governmental perspective, but from the entire panoply of institutions and individuals and forces that must be brought together to make this work. Delighted to have you here, Janet. And when Janet is done, Ray Campbell, who is the Executive Director and the CEO of the Massachusetts Health Data Consortium, an effort at the state and local level to share information and in all the activities required to understand what information should be shared, how it could be shared, and how we can create sustainable incentives for that sharing to take place. So, Bill, let me turn to you. Can you lay out for us what you were seeing as how we are doing, what we're not doing so well, and in particular, what the leadership lessons are and the next steps ought to be as you see them?
Sure, thanks, Jerry. I put forward this one word, interoperability, as a focal point, but when we're talking about leadership in the revolution of healthcare that has to go on over the next decade or so, I think it's important to keep in mind that leadership is critical, but no one leader can do the job. This is a huge problem that's going to require leadership across the country and, in fact, across the world to make it work. The figures I put up on the screen here are not a mystery to anyone. They've been around for quite a while now. We are killing people unnecessarily in healthcare, and we're costing a lot of money and wasting a lot of time. These problems are due to the fact that we, in general, are still practicing medicine as if it were a cottage industry. Hippocrates, 4,000 years ago, practiced medicine under the plane tree, where the physician and the patient got together, and eventually paper records were being kept by physicians dealing with individual clinicians. And everything was done from memory from the patient, memory from the clinician. And what we have to do is look at the change in this paradigm. We have to get rid of the paper, which has got a lot of problems that most of you already know about, and change the paradigm of decision-making in healthcare so that it includes the electronic health record system and the intelligence that can be built into that for both the patient and the clinician when they're talking about their health. The issue here in terms of interoperability is that this interaction has to be supported by a clinical decision support system, a software system that does not stand alone. It needs external data sources. It needs rules on what the best practices are. It's got to feed data to public health and quality reports to clinicians, payers, and the public, and complete this feedback loop that we seem to fail to do in healthcare to produce results, quality results, from the everyday clinical interactions and feed it back into the best practices so that we don't continue to practice medicine the way we have been in the past. We have to close the feedback loop, we have to make it faster, and we have to make it more efficient. So this goal of high-quality, cost-effective healthcare really means, from an IT perspective, that the clinician-patient interaction has to have clinical decision support involved. That by itself requires an electronic health record system with a clinical decision support software, and 4 inroads that we have to find as leadership in this country, ways to bring together. We need interoperability with the sources of clinical data. We need interoperability with the national sources of rules for best practices. We need incentives to incorporate these things into healthcare practice, which don't exist today. And we need to investigate the systemic failures to allow building systems that detect and prevent errors. This is not magic in any way, but the challenge is huge. We have this concept of interoperability is perceived by different people in different ways, and the whole picture of interoperability involves not just standardizing the messages that convey information from one place to another and making those conveyances secure, but supplying network services like locating patients and terminology and the rule source and so on. And all of that has to be done in an environment of trust. We need to be able to trust the identification of our users and our providers. We have to authenticate them to make sure we know that we're talking to the right people. We have to assure that we're accurately linking patient records with the patients and give patients control over access to their information. We have to mesh the workflow of businesses which have been sort of grown up in a fragmented way, and we need contracts and agreements that have a common basis. We need organizational interoperability as well. Keep in mind that the healthcare system, from my perspective anyway, is the most complex human endeavor in history. And yet, it's fragmented, and we have yet to move fully into the industrial age for healthcare, and we're banging on the door of the information age and running into these problems of interoperability. The key that we have to keep in mind is that the current healthcare system is not reliable. A patient's course and outcome depends on this complex system of information exchange between different providers and different roles and different places at different times. And smoothly interconnecting these roles and the information is difficult, and it's error-prone, but we have to make it work. Otherwise, we will continue to rise the cost of healthcare at outrageous rates and continue to hurt people unnecessarily. So, taking some good words from work that other people have been doing on patient safety, we have to realize that blame and the accompanying threat of punishment and stigmatization that we seem to have in the healthcare system activates defense mechanisms and drives out information about what our system's vulnerabilities are, and it stops us from learning how to do it better. It undermines our potential for improvement. So building higher reliable systems requires that we adopt the systems approach. We have to understand how the breakdowns occur, how to support decisions in this increasingly complex world of healthcare. We have to move beyond the culture of blame, create an open flow of information, and learning about the vulnerabilities to failure, which requires leadership to build partnerships across all stakeholders and set aside differences to make progress on this common goal of better health care for all. So, I'm skipping a lot of the stuff in my slides there that you can take a look at your leisure, but just to get to the point that this vision of interoperability, I believe, is at the core of a necessary transformation that healthcare has to go through, but that the vision is typically incomplete when you talk to a leader, and you've got to put all of the leadership together and make sure the vision is whole and that everybody understands where we're going in order to put all the parts together. Only recently has the information system capability been realized, and that technology is now capable of implementing these kinds of systems. The many complex parts and interacting parties have to get together and stop blaming each other for failures. We need to gather information and solve the problems rather than blaming each other for the problems and moving on because the problems just keep happening. We have legal and cultural practices in healthcare that prevent no-fault findings. They prevent movement toward solving systemic problems that we need to deal with. Our incentives are contrary and inconsistent. so that we can't get information technology in healthcare in reasonable ways. And we have to deal with the information privacy and security issues. These are critical to success. Without the trust that are built from solving these problems, we can't exchange the information, basically. Our government role is growing, but it's incomplete. We are doing research, but not building the infrastructure necessary for this to happen, and which I think is a government role. And the private sector is slow, extremely fragmented and competitive, and doesn't necessarily refuse, but pretty much ignores the opportunity to standardize and compete on the quality of what they're doing as opposed to trying to isolate their particular customer base. So, as a leadership group, bringing the whole vision together, making sure everybody understands it, and building all of those elements of the system in a way that's interoperable, we will finally get people to come to the system and provide better, high-quality care. Thank you.
Bill, thanks a lot for that. That was very instructive and a lot of detail. For those of you who are interested in rapidly taking notes as you go along, you do know that you don't need to do that because we will make these presentations available to you as a follow-up. But Bill, let me ask two questions in following up. You've laid out pretty much of a vision yourself as to what the end state ought to be in a system that's very complex now, and we have a tendency to blame too much, but we need the kind of interoperability on the data, on the rules, on the incentives. We need to get aligned so that we don't have that kind of systemic failure. My question is, if you went 10 years ago and now look now at the point in 10 years to the future, and you put this whole thing on the scale of 100% is what we could be doing, are we still where we were 10 years ago? Are we 10% of the way? Are we 90% of the way? And do you see us getting there to where we ought to be in the next 10 years or not? I'm just trying to put your vision on a pathway over time and your sense of how far we've come and how far we have to go.
Well, it's a hard question to answer because my initial expression of this vision was done in 1966, and I figured it would take about 10 years to get there.
Mm-hmm. That's when I was doing nursing care initial guide stuff. 66.
So, what can I say? We are in a situation now where in the outpatient ambulatory environment, about 5% of clinicians have these kinds of capabilities, even though they're not fully implemented. At least their hospitals are in the 15 to 25% range, but most of those are not fully interoperable. They're bits and pieces of systems not fully integrated in the way that my vision portrayed. So my expectation is, given all the activity that I'm sure Janet will talk about in the regions and in the states and in the legislatures and in the governor's offices, that we will make a lot more progress in the next 10 years than we have in the last 40.
Mm-hmm. I know you've talked about this issue with analogies to what happened with TCP/IP. There was a time when networking was held up as a vision that would be very powerful, but with the world of IBM's SNA and DECnet and proprietary networks, we didn't get very large networks until Vint Cerf and Bob Kahn created sort of in the skunk's work through DARPA the TCP/IP protocols that, when they took off, ultimately reached a critical mass and then just exploded. Do you see an explosive capacity that we're maybe going to get to in the next several years in the healthcare arena?
I do. I think that the Internet took off very quickly because the government sponsored an infrastructure and the set of standards and built a working prototype. And they rolled it out to sort of test environments, mostly universities. And then finally, a couple of things were added to that, and things took off. And finally, general services were available, and then specific vendor products and services attached onto that, and it's just totally exploded. I think the same thing can happen in healthcare, but understanding that it's a much more complex environment. The infrastructure has to be a a secure mechanism of communicating between people in the healthcare system where the people on each end of the communication are absolutely certain about who they are communicating with. The authentication and identification of the parties who are communicating is critical, and the, of course, encryption of the communication itself is critical. Now, we have the technology to do that today, but that nobody has stepped up to sort of install this infrastructure to set the standard and say, okay, here it is, use it if you want it. And I think if we did that, particularly from a government perspective, it would be a huge step forward, and we would see the private sector jump on that and make a huge step forward.
Okay, last question that I have for you, and I'd like the other panelists to ask a question of you, and then I want to turn to Janet. But you mentioned earlier that there's no one leader that's required to make this happen, but multiple leaders, and yet it raises the question, at least in my mind, of what are the key leadership roles, and is there anybody in particular who's doing a great job and anybody in particular who hasn't stepped up yet? That would give us a sense of really where the next steps ought to be taken on the leadership agenda.
Well, there's lots of activity, but I think if we look at what the challenges are, we can look at who's providing the leadership in each of the areas that have to bring the different aspects of interoperability together. We have the Office of the National Coordinator under HHS trying to put together standard messaging formats for communicating. We don't have anyone who's stepped up yet to do secure conveyance standards, but I think the Office of the National Coordinator is thinking about doing that sometime in the next year or so. Mm-hmm. Network services are things that people and companies are working on sort of independently, waiting for the infrastructure to jump on. Mm-hmm. And they are contracting with individual organizations doing health information exchanges, for example, but not doing it on a national basis. The Agency for Healthcare Research and Quality, their sort of primary role ought to be this national rule source. And the National Library of Medicine probably ought to be providing the terminology service. And I think they're inching in those directions, but without the rest of the leadership coming together and demanding that they do it now, that is going to continue to be a very slow, when we can afford to do it kind of movement. I think
I'm sorry to interrupt. I wanted to have you finish that idea, but then I wanted to turn to Janet and to Ray to say, do they have any questions of you at this point?
Sure thing. I'll just point out quickly that people are working on the trust issue in terms of figuring out what the business practices are across the country and how they prevent communications from happening, and trying to find ways to solve that. And Connecting for Health under the Markle Foundation is trying to work on the organizational interoperability by coming up with model contracts and agreements. And as Janet will talk about, I'm sure various organizations, states, and governors' offices are putting together local efforts to do health information exchange and try and solve these problems on a local basis. So it is coming together, but it's still quite fragmented.
Your 1966 image or vision has not yet gotten to where you had hoped.
No, but we are moving in that direction.
Good.
More and more rapidly.
Janet and Ray, do you have any quick follow-up with Bill?
Hi, Bill. This is Ray. I did want to follow up on one point, because I think that you did a great job of conveying just how many barriers and how much complexity is involved in this particular issue, and how much needs to be accomplished in order for us to get to the ultimate end state. The barriers that I guess lately have been looming largest for me, in terms of somebody who works on these projects at a statewide level, is you talked about the alignment of the incentives is not that favorable, in the sense that a lot of these investments need to be undertaken by doctors, whereas a lot of the benefits will flow to other people in the system. And you also talked about how in some ways, medicine remains a cottage industry in this country, that it's almost a pre-industrial from a supply chain point of view. And those are two barriers that really, I think, here in Massachusetts, we find very difficult to find our ways around in terms of, via local initiatives, because if the doctors aren't capturing the benefit of these investments, it's really hard to get, no matter what amount of leadership there is, it's hard to get the doctors to invest. So, what are your thoughts on these sort of structural barriers and what you think might eventually, erode them?
Well, I think some of the work that Janet and the eHealth Initiative have been doing on incentives is critical, means of finding ways to make health information exchange support itself, and she can talk more about that. I think from the cottage industry perspective, doctors get a bad rap. They are thought to be Luddites. They don't want to adopt the technology. And we have to put in perspective the fact that doctors have been proven to adopt technology when three problems are solved. If the doctor can provide better care to their patients in less time and for less money, or in fact getting reimbursed for the time that they put in, when those three things are solved, they will buy the technology and use it in a flash. Just look at how fast CT scanners were adopted in hospitals when the use of the CT scanner was paid for by Medicare and other payers. It provided better patient care in less time and, from the perspective of the provider, for less money. And they adopted it overnight. Every hospital in the country has one of these things now. And half the doctor's offices have one too, so even though they cost millions of dollars apiece. So I think we have to keep those two things in mind when we talk about incentives and ways to move the doctors out of the cottage industry.
Great, thanks.
Super. Janet, do you have a question, or can we turn to your set of ideas? Feel free to pursue either way.
I do have a question. Bill, you've spent a lot of time in leadership within the government and out in the field, and particularly in privacy and security, privacy and confidentiality issues. What does your crystal ball tell you, or how do you see the environmental landscape around these issues over the coming year or 2 years?
Well, as we've talked about, privacy and security are major barriers to information exchange until people feel comfortable that their information is protected and secure. And I think setting standards at a national level, as the Office of the National Coordinator is trying to do for the security aspect, solves one of the major problems. When we go out and talk to the states, their major issues about security are typically authentication. How do we figure out who somebody is when we don't see them face to face? And how can we be assured that only they receive a message sent to them and only they could have sent a message that we receive? Those are technologically easy problems, and they can now be solved cost effectively if we can only, as a nation, stand up and say, this is the standard for doing it, go forth and do it. Mm-hmm. The privacy issue, I think, is coming to a head. That is, with the project that RTI International is doing for the Office of the National Coordinator, we're gradually raising the awareness of this problem across all of the states. They are working together now to come up with solutions to deal with the fact that there's a HIPAA privacy floor, if you will, and every state has a variable implementation that goes above that, and they are now becoming aware of the fact that those ceilings above HIPAA are inconsistent. They're not based on policy, they're based on habit and happenstance, and coming up with for example, we don't know exactly what they're going to come up with yet because they haven't finished their work, but I suspect it's going to be something like a model state law that implements privacy issues above what HIPAA provides as protection. And when most states adopt that with the minor tweaks that would be necessary to adapt to the various cultural differences, then we will feel more comfortable that the technology can step up and provide ways of sharing information across barriers of state and region without dropping the particular privacy and security issues that that particular region requires.
Super. Bill, I think you've done a wonderful job in laying out a very complex topic pretty concisely. Janet, let me turn to you now and take it from here.
Thank you, Jerry. There is a lot that is now happening. I have to tell you, more than I thought would happen in such a short period of time. A number of forces are emerging at multiple levels of the system, and enormous progress is being made, I believe, on the vision that Bill presented. And we do a lot of work at multiple levels of the system, at the national level, the state, and the local level, and we're beginning to see some trends fall out of what's happening. Standards are beginning to emerge at the national level. We're seeing some seed funding. We're seeing a number of states, and I'm going to talk a little bit about this as well, having dialogue, putting together multi-stakeholder planning committees, and agreeing on some policies for information sharing, and Bill talked about that as well. At the market level, what we're seeing at the community level is actually the data flowing, or the creation of these health information networks, and business plans for their sustainability is happening at that level. And then, of course, within individual hospital systems or physician practices, we're also seeing changes happening at that level, and some indicators of consumer engagement in all of this. So I think what we'll see, and what we're seeing now, is forces at multiple levels of the system. And I'm going to do a quick scan over the next.
Let me interject you one thing just very briefly. On those forces and that progress that you're seeing through them is, again, your time frame a long one. Should we think of progress as reaching some sort of critical mass phenomenon and something that is ripe for what would be substantially different from the past, or will this be since 1966 we've made a lot of progress, but it's going to take us another 20 years to get very close to what Bill was talking about?
Well, that's a good question. The President has set forward a goal that nearly every American will have an electronic health record by, within 10 years. And I think we're in the second year of that. Do I think that will happen? I don't think so, but I think we will see within 10 years a critical mass of the different parties in particularly large urban areas being connected in some way electronically. So I think that will happen. Will we touch every nook and cranny of the United States, every physician office? I don't think so. But I think what you're seeing, and the trend we're seeing now, is in large urban areas, whether it's New York City or Indianapolis, Cincinnati, fairly large urban centers are the key players, the heads of the hospital systems, the labs, the physician offices are starting to develop plans for mobilizing data.
Okay.
And so when you look, I've pulled together a couple of key slides around what's happening at multiple levels of the system. And a couple of things. At the national level, Bill talked about standards, and we're seeing that emerge quite rapidly, actually, at breakneck speed. Standards for interoperability are emerging, and it really came out of, and I think was stimulated by, an executive order issued by the President back in August of 2006. And there are a whole set of processes and committees that are funded by the federal government that are helping to make sense of the standards out there and driving some adoption. What we're also seeing, and we're going to see this very much so in the next 12 months, is that the federal government is putting its money where its mouth is around standards, and actually with its vendors and contractors, folks that they work with, will now need to require use of the standards that are coming out. And the first step set was accepted by the Secretary back in December and will go into place 12 months later. But it's not just at the government level. What's happening is also that the Secretary is moving out and talking with governors in the private sector, and in fact has gotten sign-on from a number of private sector purchasers and employers to also sign on to this notion of standards. Other things that are happening at the national level around policy is some congressional action. Last December we saw movement around changes in payment policy. When Bill talked earlier about incentives for small physician practices, we're beginning to see some pressure on the system to do voluntary reporting of performance by physicians. And when you think about how to do that and how that gets done, it's going to be increasingly difficult, in particular with some of the requirements beginning on January 1, 2008 to get there without the use of electronic healthcare systems. And then finally, we're seeing the private sector actually kick into high gear. A number of large employers in our country have gotten together and developed a toolkit and a set of requirements that they'll put into contract language for those they contract with for health care. And we're seeing a number of financial incentives systems happening. And then going back to something we talked about earlier, in addition to that, you are seeing some interesting announcements around this notion of personal health records. Things like Dossier. A number of large employers are now reaching out and building patient-centered systems for care. What we're seeing is not only at the national level, but also at the state level, and this is something we track pretty carefully. And I'll tell you, 3 years ago, not much happening, but in the last year and a half, last 2 years, we've seen a lot of advancement at the state level. In fact, 19 executive orders were issued by U.S. governors in 15 states around the use of health IT, and 7 of them were in the last couple of months in 2007. So a number of governors are making this part of their activity at the local level. We're also seeing a good amount of state legislative activity. Again, this is a new phenomenon. It's only in the last couple of years we're seeing, let's see, I've got some data points here on the slide. Half the states have passed and signed into laws bills related to healthcare information technology. And again, this year early, we've already seen, and this data is about 2 weeks old, 68 bills introduced in 30 states in our country that are specifically focused on IT. So a lot is happening at that level as well.
Are those bills, and is this information you're reporting on fairly consistent in your view with what the right solutions ought to be, or are the bills competing against each other in drastically different directions?
Most of them are really about the beginnings of this. They're authorizing a commission or a committee or a task force to develop a roadmap or develop a set of recommendations. So we're in the early stages. We are seeing some funding emerge through various, authorizing of funding or loans or grant programs, particularly for this notion of health information exchange networks at the local level, which is really promising when you think about building the nationwide health information network from the ground up, which we think it's going to be a combination of local initiatives building with the alignment of incentives and then also supported by national policy, and perhaps this thin network around record locator services and the like that Bill talks about.
Mm-hmm.
Let's see. So, going back to our multiple levels of the system analogy, so we've talked about national policy, we've talked about what's happening at the states a lot. And then as I mentioned before, there's a lot of activity that's actually happening at the local level, particularly around what we call medical trading areas, or where we as patients go to get our health care and where our physicians and other clinicians, the referral patterns in a market. And we've pulled together some survey data around that. And there's great progress being made in that area. So when I think about where we're going to go from here and how this is all going to come together, I think there are a couple of ways that I can share this with you. If you take a step back and you look at the national policy picture, you're seeing a lot of things happen around healthcare IT policy, a lot of pressure around payment reform emerging, particularly from employers and Medicare, Congress, trying to squeeze more out of the healthcare dollar and also drive for better outcomes. So you've got those two things at play, as well as an increasing consumerism, or the public getting more engaged. And we're, I think, really at the early part of that. But as baby boomers get older and we're very demanding, demand more from the system as we do with all other parts of our lives, I think that these forces could work together quite nicely. And actually, Ed Wagner and others created or developed a paper talking about, okay, maybe we won't get to healthcare reform, but here are some strategies for reform at the regional level. And he talks about these same areas: aligning incentives, engaging the public, and using information technology. So I think as we look forward, it'll be at the intersections that this happens, and you'll see these emerging networks. And we're already seeing them, but they'll be used for multiple purposes that are around improving healthcare, perhaps around public health surveillance or research, or things that actually provide value to the various stakeholders in the system in order to drive some sustainability. And I've got some data points here around what's actually happening out there. And this is almost a year old, so we're getting ready to conduct the next survey. And there's actually about 1/5 of the 165 markets we surveyed are actually beginning to exchange these types of data.
Mm-hmm.
The other thing, and getting back to business-wise, how one makes this happen is, and Bill talked a little bit about aligning incentives and how that's one of the key barriers to having, and Ray also, to making this happen in the marketplace. It strikes me that using these health information exchange platforms to actually deliver services that provide value, that are not only related to care delivery, as I have in the slide, and many of them in their first round of services are doing that, but you're seeing a trend towards other valuable services emerging, whether it's chronic care or disease management, or even this performance reporting, which I talked about earlier, particularly in light of some of the forces that are coming about from large employers and payers, and maybe we'll see some consumer access to information demand in all of that.
Mm-hmm.
So long story short, I know I'm coming up on my time. If I were to take all of our learnings from our work at the national level, our work with states, we helped a lot of states out in the country develop those roadmaps I talked about, as well as what we're seeing at the local level, some key themes are emerging. The first is, and I didn't talk very much about our research around value and sustainability, but one thing we learned pretty quickly with some of the advanced stage initiatives is this notion of multi-stakeholder collaboration and the building of social capital at the local level where this data starts to get exchanged. The other key theme is I think this will be building the network from the ground up using national policies. So I think it's going to start at the local levels with support from folks at the national level. And then doing all of this, I think our challenge in the months ahead is doing all of this while maintaining public trust and assuring privacy and confidentiality. And I know that's top of mind for many of the state and local leaders that are making this happen, to be sure that we do this in the right way, engaging consumers along the way so it gets done well. So that concludes my remarks.
Super. I want to tell the audience to get your questions ready, because when we get through Ray here quickly, we want to just open it up to general questions and answers. Let me actually ask Bill and Ray if you have any questions of Janet. I have one question of Janet, which goes back to the same question I really asked to Bill when we started. As you look at these activities that are very important and your conclusions as to what needs to be done, can you make some observations about the leadership that will get those things done? In particular, where do you think we've been strong leadership-wise, and where do we need to strengthen? Where have we been relatively weak and need to bring more of the right kind of people doing the right kind of things to the table?
I think that the leadership needed, we've got significant leadership at the national level, but I think this trend that we're seeing with state governors and folks at the state and local level is very important, because that's where healthcare gets delivered, and we're seeing enormous leadership emerge from there, and that needs to continue. We're also seeing the beginnings of leadership by those who pay for health care, and I think that's going to be critical and important to moving that forward. The large employers, the business coalitions, and others. Where are the gaps in leadership? I think, if I were to make a statement about this, I would say, particularly in our research in these 3 advanced communities about separating those who fail from those who succeed, it's leadership around finding common ground amongst the very different stakeholders in the healthcare system. That's where you're going to drive real change. And so I think that's where we need to see it. And it's primarily at the state and local level.
Very, very interesting. Ray, do you have any comment or follow-up question on that?
Well, I'm just amazed, Janet, at how much all of your comments foreshadow what I was going to say have been our experiences at the local level. So I guess one question I would have is that with all the talk about interoperability, it seems to me that one of the biggest barriers we face is that you have to have business owners that want to interoperate. And very often in the healthcare economy in a particular region, you'll have competitors that are actually relatively happy not to be sharing information electronically with some other players in the system. How do you get around those types of barriers?
Yes. Well, there's some technical, what we found in this research are there's some nuts and bolts things that one can do around, most of the leaders have not gotten to the point where they're developing business plans and identifying value for different stakeholders. So that's number one. But number two, I believe that there's no reason to exchange data right now. We're not, there's no business reason, and my sense is as payment reform continues and we move from electronic reporting, voluntary reporting of performance measures to more, as pressure on the system is applied around outcomes in healthcare, it will create the business case for a lot of this to happen.
Super. Bill, do you have any questions?
No, I think Janet's right. Education of the leaders is the key. You've got to convince them. You've got to have the evidence to convince them that this is worthwhile doing, and that although they may be sharing information with their competitors in a sense, the sharing of information will raise the quality of healthcare overall and lower their costs overall, and they will get some return on that investment of sharing information. But that requires a significant amount of education and engagement, basically, that has been absent in the past.
I've got some questions, but I'm going to hold them because I want to turn to you, Ray, and just let you lay out some observations here, and then we'll get the audience questions in.
Great, thanks, Jerry. Let me do just a very quick flyover of the situation in Massachusetts, because I think that Bill and Janet have done an excellent job of describing kind of the strategy, and Janet's a lot of lessons learned from a lot of different activities around the country. I'll do a slightly more detailed drill down on one particular state and talk about some of the lessons that we've learned, and I think you'll find that they dovetail nicely with what Janet and Bill were saying. So let me just move to the first slide. I think the first thing you need to understand about Massachusetts, and I guess if you were to ask around the country, I think we're seen as one of the states that has done some of the leading work in the area of health information exchange and health information technology adoption. But we have more lessons learned than successes to date. And one of the things you have to understand about Massachusetts, and trying to understand some of the things we've done and some of the lessons learned, is that our e-health landscape is fairly complex, and that's we've got a lot of players in this space, and it's partly a reflection of the fact that we've been working at these issues for a long time. So let me just quickly go through the organizations that are involved and then talk about some of the lessons that we've collectively learned. So first is the Massachusetts Health Data Consortium, and that's my organization. It was formed in 1978 to serve as a neutral holder of health data on hospital utilization. And over time, it morphed into a neutral convener of the Massachusetts healthcare community around issues relating to health data and health technology. And that was done without realizing that, at some point in the future, that health information exchange and healthcare IT were going to be really hot and central topics to health reform and how we move forward to get a better healthcare system in this country. But almost behind the scenes and unconsciously, this community started to develop in Massachusetts around the work that the consortium was doing. And my predecessor in this position, Elliot Stone, spent 27 years cajoling all the different healthcare organizations in Massachusetts to find different technology or data projects that they could work together on. And so, almost without realizing it, Elliot built up this huge reservoir of goodwill between the various people at the different organizations, many of whom are often competitors. And it was through that sense of community, or the trust that was engendered by Elliot's efforts, that a lot of our collaborative projects have come to be. So one of the most important of these collaborative projects is called NEHEN. It was formed in the 1997-98 to do HIPAA-compliant administrative transactions. As of today, it now has 48 hospitals and 8 health plans participating in it, and it processes 50 million transactions per year, or about 80% of all the healthcare claims transactions in Massachusetts. So out of this culture of collaboration that the consortium created came this very specific project, the New England Healthcare EDI Network, that has now become the backbone of how we do claims processing in the state. So it's a very tangible expression of how a willingness on the part of competitors, because the 48 hospitals that are part of NEHEN definitely see themselves as competitors, and the 8 health plans that are part of NEHEN definitely see themselves as competitors. And yet here was a successful example of how they were able to come together, collaborate, and in a way that benefited everyone. The cost of processing these transactions has dropped dramatically from when this was being done in paper. So the next initiative that people decided to undertake is called Mass Share, and this was an attempt to do with clinical information what had been done already with the administrative data, and that is to set up a utility service almost that could start sharing the information between different healthcare organizations in Massachusetts. This group, Mass Share, there's no official designation, but it's the de facto regional health information organization for Massachusetts, and we have extensive state government involvement in it, and we're generally looked to as the organization for health information exchange projects. I should mention Mass Share is a subsidiary of the Mass Health Data Consortium. And to date, the main areas of emphasis for Mass Share have been around medication histories, making those available to doctors in emergency rooms, a thing called the Record Locator Service that was developed with support from the Markle Foundation, an e-prescribing gateway application that simplifies end-to-end e-prescribing, and then also some results delivery type services that we're now starting to pilot. The next organization is the Massachusetts eHealth Collaborative. It was $50 million provided by Blue Cross Blue Shield of Massachusetts, and it's a very interesting project. For my money, it's the most interesting eHealth project going on in the country, because instead of the usual inch-deep, mile-wide approach to these things, they've instead selected 3 communities, and they're going to be providing every single healthcare provider in those 3 communities with an electronic health record and enabling electronic health information exchange between all those providers. So we're really going to see in reality what it looks like when you have a completely electronic community of care for healthcare delivery. And then lastly, I want to mention that our quality improvement organization, whose name is MassPro, was one of the 4 pilot states for the docket program, and they've done, I think, over 2,000 doctors they've assisted with deploying electronic health records. So that's the landscape. It's a complicated group of players. Happily, there's a lot of cross representation on the different organizations' boards, and so we tend to work very well together rather than being competitive with each other. There's a relatively clear division of authority that we tend to follow. So anyway, in terms of just quickly running through some of the lessons learned, this next slide definitely echoes a lot of what Janet and Bill were saying, and that's that many aspects of doing e-health are inherently multi-stakeholder in their nature. I mean, there's certainly some things that can be done, like a hospital internally updating its systems that doesn't really involve a lot of organizations, but most of the interesting things in health information exchange are inherently multi-stakeholder. And what we've learned over time, and it's, I guess, not a big surprise, but it's that successful multi-stakeholder initiatives require a critical mass of collaboration. You need to have enough organizations that represent enough of the market coming together, willing to collaborate, or the collaborations tend to fizzle. And to have that meaningful collaboration requires trust. And as I note in the last bullet, trust is built over time between individuals. There's really no substitute, I think, for taking the time to have the different players and the different organizations get to know one another, and particularly to work on projects together and start having some shared successes that they can build on. Mark Overage in Indianapolis often uses the expression, start doing laundry together if, joint laundry services is the only thing you can find where you can start collaborating and learning how to benefit from working together. Mm-hmm. The next set of lessons learned is that success requires solving 3 interrelated set of issues simultaneously. There's technical issues, but there's policy issues and also business issues. To date, I think there's been relatively more emphasis and progress on the technical issues and less on the policy and the business issues. Massachusetts is now getting ready to do a big push on privacy and security issues, but in the specific context of consent management. We think that a lot of understanding privacy is understanding how people's wishes can be implemented in a more granular and subtle way than just the yes/no of kind of a HIPAA release form that people sign. We think that understanding what it is that people are willing to share and under what circumstances, and finding a way for the systems to reflect that reality is going to be a big part of solving the privacy concerns that people have about this stuff. The last bullet point on this page, scale really does count, and this goes to what Janet was saying just a few minutes ago. The community of care seems to be the logical unit of organization for a lot of the HIT and HIE efforts. National standards are great, national thought leadership is great, but this stuff tends to make the most sense when you're talking about the community within which people actually receive care. In addition, business sustainability requires offering a service that generates new revenue or avoids costs for participating members, and this is a harsh test. We've provided a lot of potential services to organizations trying to roll out health information exchange projects, and what we've learned is that even though these are very altruistic people, a lot of the organizations in Massachusetts are nonprofits, people want to do the right thing, but at the end of the day, they have limited budgets, they have limited resources, they have limited personnel, and if you're going to get onto their priority list, and these tools aren't as simple as flipping a switch. For an organization to embrace health information exchange, there's some change management involved, some workflow redesign. It's a non-trivial undertaking, and frankly, to make it onto their priority lists, it has to make business sense for them. It either has to generate revenue or avoid costs. That creates the problem that a lot of healthcare organizations are already undertaking the health information exchange projects that make business sense. I mean, we're seeing that in Massachusetts, where different hospitals that have affiliations for whatever reason, or they're part of the same network, or they share special referral patterns, they're starting to just build these point-to-point connections themselves, and everybody says that doesn't scale. Well, that's true, but I guess the question is, right now, we're not hearing organizations say that they're worried about scaling up to the entire country. They just want to be able to communicate with their business partners. And so sort of almost a cherry picking is going on in the sense that what it leaves for RIOs, this last bullet point is tongue-in-cheek, and actually I dropped a word, but the challenge they're being asked to do is to achieve sustainability doing health information exchange projects that don't make business sense. The ones that do make business sense have been undertaken by the market participants.
Can I interject just a little bit on
Sure.
this, Ray? Could you give some examples of the two previous ones that you were indicating? Which ones have been implemented because they do make business sense? Which ones have had uphill going because they may make sense for the nation as a whole, but not for the businesses that are engaged at the moment?
Sure. Well, one example of a project that makes business sense is that there's a large hospital on Boston's South Shore that has decided to partner with the Brigham and Women's to do all of their cardiac care cases, and so they're referring a large volume of patients with heart disease from their hospital to the Brigham. In terms of getting the data back and forth between the two, they had discussed the idea of using the Rio, but the reality was it was just simpler, easier, faster, cheaper for their two systems vendors to create a bridge between their two systems and avoid the whole Rio thing. So here was a case where two business parties needed to be sharing data, and they undertook it on their own dime because they really just needed their two systems to talk. They weren't trying to talk to everybody in the world. They wanted an airtight fit between the cardiac care systems in one hospital and in the other. So that's a case where the exchange made eminent business sense, but instead of the Rio doing it, the parties did it directly. So it makes it difficult for the Rios to find a sustainable business model when, very often they're left to do the exchanges that the parties don't undertake on their own. So it's just a realization that's starting to sink in with us that all the best transactions, it seems, get done on their own merits, and then the Rios are left to try to piece the other things together. And so that feeds into this the last two bullet points. Transformation, is it going to come about because everybody decides to hold hands and be transformative because, by gosh, it's the right thing to do? I don't think so. I think that it's either going to come about by one of two ways or a combination of the both. One is through central planning, and that's using the power of either the federal government as a regulator or as a purchaser or through some other mechanism to start changing some of the incentives that make this stuff so difficult to do. So that's kind of a centrally imposed view of transformation. Or the other way, and I think in my mind the preferable way, is to increasingly allow information to flow more easily throughout the system so that market pressures can start to come to bear, that people will start demanding services from people that have very transparent processes, that have good quality and cost information available about them, and that transformation occurs not because people are trying to do it, but as a byproduct of all these systems we're implementing. And then just the last point is that I think the final destination is far, far away. This is going to be many years that we'll be working on this.
Got it. For those of you who are out there with the questions, I see that Governor Geringer has got an interesting question queued up, but I want to go back briefly now to Bill and Janet to probe Ray with any follow-up questions on his ideas. Bill?
Ray, the question I came up with was that Massachusetts is one of very few, maybe 2 or 3 states, that actually has brought together the majority of the payers and providers in a trusted relationship where they can actually implement some of these things. What's your secret, and how can we roll that out to other states?
Well, I think that the secret is to start creating human relationships between the payer and provider organizations and the government organizations, and that takes time. There's really no substitute for time, but I think that the mere presence of an executive order or some impetus for the stakeholders to come together in a room, that tends to result, I think, in people just keeping their cards close to the vest. To really have collaboration requires trust, and I don't think there's any substitute for just taking the time for direct personal relations between the CIOs in particular, but also some of the business leaders in these organizations. I think that's how you get collaboration.
Mm-hmm. Janet, what do you see as a follow-up for Ray?
I maybe have more of a comment than a question, but I just, in understanding what's happening up there and in talking with Mickey last week, Ray, I mean, it's particularly what's happening in the 3 markets is pretty amazing, and I think will be one of the first in the country around mobilizing information and also providing electronic health records to small physician practices. And it strikes me that there's just heavy lifting. It's hard work, working through all the issues, whether it's the data use agreements or making the workflow change happen in the practices. So just an observation I had about the enormous leadership up there of you and your colleagues in Massachusetts.
Well, I would agree with you that the eHealth Collaborative is just the stuff that they're learning day in, day out, and the incredible leadership that Mickey provides is really, it's phenomenal what they're learning.
Mickey is Mickey Tripathi in this case, who is the CEO of the eHealth Collaborative. And we at the Kennedy School always take credit for the fact that he is a graduate of the Kennedy School, but I'll let that.
As am I.
Right, we tend to stack this a little bit, but that's good. I think we're about ready to open things up to the audience. And Governor Geringer from Wyoming, who is no longer the governor but still has very good questions, has one sitting here. He says that state leaders will want policy and principle options to pick among, not just one choice. Who among possible leaders might draft model legislation for state or to give legislators and governors options to consider? Janet, maybe that's naturally to you, but I'll throw it out there to any of us.
Well, first I want to say that that's absolutely right. And I don't think there is a one-size-fits-all solution to this problem. And you know, we used to think this is just a national health policy issue, and we learned very, very quickly, particularly with our work at the state and local levels, that it simply is not. So that's the first. But the second, I think there is some good work that is now just emerging. I think we'll see over the summer and in the early fall there's a state eHealth alliance led by Governor Bredesen and Douglas, who are beginning to think through some policy options for how to make this work. In terms of technical alternatives, there were some prototypes that were funded by the federal government, and hopefully we'll see some of the results of that to inform models. And Bill Braithwaite also talked about Connecting for Health. There are some architectures and actually code and principles and policies for how one might approach this in one way versus another.
Ray or Bill, do you have any response to the need for multiple options and who might be drafting that sort of stuff?
Well, this is Ray. I'll jump in and say first, I think it's a great question, because I think that having multiple options will be very important, because the goal will be to do these things in a way that they can sync up at a national and regional and statewide level, but while also reflecting the fact that different states around the country are very different and may choose to approach different parts of this in a different way. So I think that a one-size-fits-all approach is probably not going to fly. And I think the governor makes a great point about making sure there's some options. I'd also like to point out one concern I have with state action, and even though I'm from Massachusetts, I'm something of a limited government person myself, and I worry that I think government action is particularly useful when there's a very clear end point, or when you have a clear understanding of how you want to get from where you are to where you're going. I'm personally in favor more of a experimentation and iterative learning model at the present time, because I think there's enough uncertainty about how this stuff is all going to eventually come together and work out that I'd be reluctant to see a state thinking it was going to steal a march on people by, becoming very proscriptive about what people need to start doing, because I think how this all comes together in the long run is still not clear.
So when you said altruism won't work, but you laid out basically government action and market action, you're suggesting, if I'm hearing you right, that there's a lot of room yet for market players to in some very competitive ways try out different approaches and learn more, that we're not quite yet to the point that maybe I mentioned Vint Cerf and Bob Kahn took us with a lot of experimentation around how the standards in the networking area got to the point where they were ready for prime time and sort of took over the world. We're a ways yet away from that, as you see it?
As I see it, but I do think that the government doesn't need to sit on its hands. It's a major purchaser, and I think that Secretary Leavitt's transparency agenda is probably about right. Let's make sure that we've got a full flow of information so that the participants in the system can start reacting in the presence of some data rather than just, in the past when things were done, without a lot of information at our disposal.
And this is Joe. I think the states working in the ONC-funded health information privacy and security groups across the states are going to come up with some recommendations. And I suspect that they will get together maybe with the NCCSL or some national organization like that to draft model legislation for the states that has those options built in.
Let me turn to another question we have, and also ask the audience if they want to submit others to please do so. But the question is, what are the most effective strategies of national support for innovation at the local level?
Money.
Yeah.
Money structured in what way? With what strings or lack of strings? Money clearly has been very central to getting human beings to do almost anything. How would you structure the money process from national to local in this arena?
I think, and Janet knows a lot more about this than I do, and Bill as well. I think payment reform is probably the best way to get the money to support what we're trying to do rather than impede it.
Go into that in a bit more detail.
Well, just that, for instance, when you go to see your, doctors get paid for office visits. You have a great email exchange with your doctor. It's better for you. You find out what you need to know. You don't have to go to town. It's more efficient for the system. Everything's great. The doctor doesn't get paid for that. Well, then he's not going to be doing a lot of email consultations. So if you reform how we pay and what we pay for, with more pay for performance and outcome-driven payment measures, I think that is the type of thing that will just inevitably force doctors to adopt technology more quickly because it will, dovetail with their incentives.
Now, do we need more experience in places like the Mass eHealth Collaborative to find out what incentives will work and what the real problems are, or is this something that we could get people around the table and they would come out with a pretty good answer if they just address that problem directly?
I think we probably know enough to start making improvements in the incentive structure. I don't think we'll reach the end state in the short term. I also, in defense of the health plans or the payers who haven't stepped up to the plate to fund a lot of this stuff, the truth is that left to their own devices, doctors will fail in their implementation about a third of the time. This stuff is fraught with problems for very small practices, and so I think what we need are successful implementation strategies like, I think, the Mass eHealth Collaborative. And then I think you can start talking about funding at a large scale. But I think you have to make sure you've got a model that works before you're throwing too much money at this.
Janet, you had earlier mentioned that the federal government was starting to put significant money into this, and it sounded to me like a fairly optimistic assessment. Do you have any advice for the federal government when it comes to proper ways to support local innovation?
Actually, I'm thinking we're not going to see very much funding in the way of grants or contracts to support these initiatives at the federal level, but we're seeing a lot more of it actually emerging at the state level. And when I think about your question, national or maybe state level policies to stimulate innovation at the local level, I think look around me and see what's worked. But it strikes me that even minimal seed funding amounts or some level of seed funding that has some criteria wrapped around it, usually matched funding, required commitment of difficult to pull in stakeholders, some setting a goal or requirements for positive outcomes around health or health care, so not too prescriptive there, but then requiring that a sustainable model or some sort of business plan be created either with the funds or in advance of getting the funds. So when the grant money runs out, the project doesn't shut down. And we've seen some examples of cases of this that have really brought communities together. just to be leaders and pioneers around this?
Let me draw a conclusion that may be the wrong conclusion, Janet, from what you were saying, but in looking to the local governments as often initiators for this, I could imagine that they are really driven by an economic development threat, that they are worried that they can't attract jobs into that arena if their healthcare costs are too high, that if the auto industry is spending $1,500 per car on health for the workers, or some number that sounded high when I heard it, that this may be a realistic set of pressures at the local level more than at the national level, and is what's generating this. Is that more or less right, or what is the explanation behind the willingness of state and local government to put money in there? Is it just that they have more money now?
So a couple of things. I think you're right from an economic development perspective, and what's interesting is this purchaser toolkit and all of the Business Roundtable and Leapfrog and many of the employer groups moving forward on this and having some expectations around clinical data flowing, transparency and cost and quality. I think that will further strengthen the economic development aspect of that, number one. And number two, we're seeing some of the states with their budgets just being worried about cost, and particularly whether it's Medicaid or even in many states, not all states, but in many states, the state government is the largest employer as well. So there are reduction in cost issues at play.
This is Bill. I would add, and I agree certainly with what Janet said, but I don't want the other three inroads that I mentioned in my talk to get lost here. Certainly changing the incentive system to make it financially attractive to install these systems is important. But if we don't have the other aspects of interoperability and the sort of fixing the system of blame within healthcare, then we are still going to be at odds and in competition and not solving the problems of errors and lack of appropriate information to clinicians and patients to make better healthcare decisions. So it has to be done as a whole. And I think the federal government has a major role to play there in terms of setting the standards and building the infrastructure on which the rest of this can operate in an interoperable way.
Super. I'm going to try to manage this towards the next 5 or 10 minutes and sort of closing down. And the last thing I'm going to do is to turn to each of our panelists and ask them for sort of parting advice, having heard our conversation and the questions that have come in. But I've got another question here, and I've got a question I want to ask as well. But again, Governor Geringer comes with a follow-up to note the following, that private companies, especially national and international, are moving toward electronic records for employees. Might we move government along more quickly by letting that part of the marketplace set the example? Panelists?
Well, this is Bill, and I think I'll start off by saying I worry a lot about that, because you end up with the private sector implementing personal health records in a variety of different ways that are totally inoperable with each other, not interoperable with the physician's electronic health records. Without the standards and the infrastructure to support the communications between the PHRs and the EHRs, I think it's doomed.
Ray or Janet?
This is very interesting, and we didn't have a ton of time to talk about trends, but there's a lot of this going on now, and Bill's right. What's basically happening is we're building parallel systems. I mean, these typically are populated either with claims data or patient input information, whereas these networks that are primarily provider-centric at this point are exchanging clinical data that come out of laboratories and hospitals and physician offices. And I guess where we want to get to is that those two things connect, but they're different worlds, different data, different incentives. And I think, in the end, that's the goal. but it's not clear that it'll happen by itself.
Everybody's feeling pressure to do something, and this seems to be an obvious and easy thing to do. But if it's not done in the context of the overall vision and direction, it's going to dead end, I think.
Mm-hmm. So this is why I talk about us being in a phase, I think, of rapid experimentation, and you're seeing almost a flavor of the day approach to this, because everybody's trying to figure out what's the secret sauce, what's the magic combination that's going to make all this come together and make sense from a technical and a policy and a business perspective. And I don't think there's any way of short-circuiting that process. I think it's going to take time before the clearly correct model emerges, but it doesn't seem to be within sight at this point in time.
Let us not forget the famous words of Winston Churchill. Americans will always do the right thing after they've tried everything else first.
A little history is helpful here. I'm reminded of something that may be a wrong example, but Malcolm Sparrow on the faculty here owns some international patents on the computational approaches to fingerprint identification. And a number of years I was talking to him about the different standards that existed around the globe. They were quite different. And they have solved that problem largely by the construction of bridges, so that in fact the world can operate not with one standard but with multiple standards and translations among them. Is that likely to be a solution to the personal health record handled corporately and the sharing of data among major health institutions and the linkage and the consistency between that information? Are we going to have multiple standards with translation protocols?
This is Ray. No, that's how I see it playing out. I think that the Uber standard, the kind of the one seamless network, that may happen sometime during my lifetime, but I think we're likely to see growth occurring by being driven by business logic from all the different participants, and eventually it'll start to link up. But it will be more, trial and error than, any kind of a coherent pattern.
Mm-hmm.
Yes, Bill, I suspect Ray is right there. But at some point, we'll have to come up with the Uber standard to serve as the sort of common lingua franca that the different implementations can use to talk to each other. And that's going to take some time.
Let me ask my last question, and then I'll turn it to the panelists for sort of parting advice on this. But it's an issue that maybe we've hinted at. I'm not sure that it's real, but it's in my mind, and I'm going to put it on the table now. I can see a health system with large providers like Kaiser and the veterans hospitals and the insurance companies, but I know that about 80%, or roughly some very high number, of actual interactions between patients and doctors are taking place in quite small medical practices, and that the record keeping in these practices is very often the old paper style, and that these folks will have a hard change management problem as they go from one to the next. Is it likely that there is enough savings in the system that we could motivate the small practices if we were willing to subsidize some sort of transition to something that might look like an ASP-provided service from outside, maybe even from the government or from some larger place, that would, become the Salesforce.com kind of Web 2.0 offering of medical record keeping over the network for the smaller practices. Is there anything like that bubbling up? Will that likely be important? And is my imagination that it's the small practices that are most resistant to this? Is that a true observation or a false myth?
I think you've brilliantly summarized what the Mass eHealth Collaborative is all about, which is that it is the small practice that's the biggest obstacle. That last mile is the hardest one, and that what you really need is assistance getting them over the hump and getting them to the point where I think that if you can get them through the transition phase with a lot of support and eliminating some of the financial barriers, they can make a go of it in the kind of year in, year out, especially with an ASP model as opposed to them having to own servers and the like. But it's getting them from one domain, from the paper domain to the electronic, and then I think you can leave it up to them, and that's the whole model the Mass eHealth Collaborative is following.
Does that look consistent at the federal perspectives? And Janet and Bill, how do you respond to that?
When I think of all the barriers to this getting done, that's the last. I think we'll get to changes in payment and standards, but it's the small physician practice and facilitating that change, which is why I was so excited about hearing the progress up there in Massachusetts. Mm-hmm. It's most of America's healthcare is delivered by these practices, and it's really hard to change, and there isn't a lot of money in the bank account at the end of the day. And I've begun to see bits and pieces of ASP group purchasing happening, but not a lot of it. And my hope is that what you're doing up there is going to spread and grow and be a model for others.
This is Bill. I think there's a lot of truth to that. I think there's some hope there, but we have to keep in mind that the money is not sufficient by itself. The model I hear from small practices when faced with this issue is free is not cheap enough, because the practice has to put in a lot of time. They have to relearn how they practice medicine. They have to remodel their business practices to fit whatever's being given to them in terms of the data flows and the way medicine is practiced. And since everybody's doing it on their own, they're all doing it differently. So there's a huge hump to get over in terms of changing the way you practice medicine and the interaction with the machine, which at this point often takes longer than scribbling something on paper. And remember, that's one of the keys to getting physicians to use it. If you can make it so the doctor gets to go home to his family a little earlier in the evening, they will buy it. Mm-hmm. But if it takes longer and they don't get home till 10 o'clock, then there's going to be a great deal of resistance.
Let me flip it back to you now, Bill. With your observation there, step back and as sort of a parting thought on where we need to go with this constellation of issues that are very big and very interesting all around the globe, not just in the United States. What are your parting thoughts for our group?
Well, I think we've pretty much exhausted my parting thoughts already. I think the key, all the things we've talked about are necessary but not sufficient in themselves. It has to be all of those things together, and we have to keep this transformation in mind. It's not enough that we get the doctors to document things in the computer instead of on paper. We have to close the feedback loop. We've got to get intelligence into the process so that it supports their decision-making and involves the patient in their decision-making. And that whole system has to work together. And when we build something that a doctor uses, for example, an e-prescribing system that allows him to electronically write a prescription that goes to the pharmacy, that's not sufficient. If it doesn't close the feedback loop, give the doctor some more information and allow them to practice better medicine in less time for less money, we're not going to succeed.
Mm-hmm. Very good. Janet, what do we do?
Closing thoughts. I just think it's a really interesting time. It's got a number of forces at play at the same time. The transparency movement, pressures on cost and pricing, health IT cropping up, and then even things, the consumerism we talked about, and even some of the the programs actually moving out in the states around providing access or universal health care coverage. I just think there's an opportunity, there's a window here to link two or more of these things together to actually see some progress. Exciting time.
Super. Thanks. Ray?
I'd just like to second that in terms of it being an exciting time. I remember I was at the Kennedy School from 1989 to 91, and I was at that time really interested in international relations. And during the 2 years that I was there, You had like the fall of the Berlin Wall and the collapse of Soviet communism in Tiananmen Square, and just, you know, incredibly exciting event after event happening on the international scheme. And I remember thinking, I can't believe I get to be at the Kennedy School for all this. And I have that same sense nowadays in terms of working in the e-health space, because there is so much stuff going on, and it's so important and so interesting, and it's so fast-paced and changing so quickly. I guess if I had to have a closing comment, it would be, you know, number one, it's just what a fortunate time to be in e-health because it's such a vibrant field. But I would say follow the business logic. I think there's been a lot of fuzzy thinking that has been premised on, you know, our ability to envision a utopia and make it happen. I think the real challenge is finding ways to get the actual market participants to realize that their self-interest lies in taking a more enlightened view to the use of information and the flow of information throughout the system.
Mm-hmm. I found this entire subject not only exciting to be exciting times like the last 5 years and the next 5 are going to be, but this has been a pretty exciting 90 minutes. So I'd like to thank the panel for your experience, your observations of what we're doing here. I'd like to step back and, for my parting thoughts, I get to have parting thoughts too, to at one level draw attention to the dog that did not bark that I advertised at the beginning of this session, which was, yes, we want to look at e-health, but I'm also interested in looking at the reforms in e-health and how they can provide potential lessons for other arenas that I think are trying to undergo similar kind of change. That is, there is a problem productivity-wise in what we're doing with healthcare, but there's a problem productivity-wise in many of the other domains of governmental endeavor. There's a problem with equity in the distribution across income and geographic regions, different ways to look at the distributional impacts of things. There's a problem in healthcare, but in other arenas as well. And there's a problem in government about being sufficiently transparent to be held as making legitimate decisions. And in healthcare, I think there are those problems, and in other things as well. In going into what we're doing with healthcare, for cross-boundary transformation, for the kind of reforms that have to take place in the entire complex system and not just one individual or one program at a time, I think I've learned a good deal in the last 90 minutes and am excited in what we can do as we get the leadership we need for cross-boundary transformation in healthcare. And I would like to invite all folks in this audience and elsewhere to look to similar opportunities and similar lessons as we try to get the leadership we need for cross-boundary transformation in other arenas as well. We overran our hour and a half by a little bit, but I think it was well worth it. Thanks again, panel, and thanks again, audience. I'm not sure when we do this next, but it will be sometime, and we'll announce it over the net. Goodbye.
Thank you.
Thanks, everyone.
Thanks, panelists.
Thanks, Jerry.